So today I'm very pleased to be here along with Emily Galley, who is our project coordinator, and then she's going to introduce herself in a few minutes to talk about our newest Deprescribing project, which we are calling Deprescribing Initiatives Using Community Engagement, or DICE, as we will refer to it throughout. So we're going to start by giving you a little bit of background on some of the definitions, descriptions of the terms that we'll be using, and then I'll give you some background information about the projects we've done over the last several years, and then we'll introduce DICE and leave it open for questions, and we hope also advice from people in the room who have some experience in the community engagement field. So I want to just acknowledge our many funders over the last several years, as well as the institutions of our close collaborators, and especially our team who's working on this. I'm not quite sure what's going on there, but happy to acknowledge Dr. James Conklin, who is also a researcher at the Bruyere Research Institute, Lisa McCarthy, who is a pharmacist researcher at the University of Toronto, Lalitha Raman-Wilms, who is another pharmacist researcher at the University of Manitoba. They're our co-investigator team for the DICE project. Emily, as well as Pam Howell, who's a pharmacist who will be working on the project as a content expert, and Steve Smith, who is here, who will be live tweeting this morning about the presentations. So polypharmacy is really, used to be described as more than 5 medications. Currently in Canada, 2 out of 3 seniors over 65 take more than 5 medications. Actually, 40% of people over 85 take more than 10 medications. So the numbers of medications that older people take are increasing. We tend to think of this term now as the use of more medications than are needed, or for which harm may outweigh benefit. And the problem with polypharmacy, whether it's numbers of medications or potentially inappropriate medications, is that increases the risk of drug interactions, adverse reactions, falls, fractures, functional and cognitive decline, non-adherence. So we actually know that the more medications you take, or actually the more medications you are prescribed, the less people actually take. And it also leads to hospitalizations and significantly higher healthcare costs. And it's particularly problematic for the elderly because they handle and respond to drugs differently than younger people. And they're often very frail, and they're not typically frail. Older people, and those with dementia, are not typically represented in research. So we don't actually have a good feel for how well drugs work in older people. So deprescribing is defined, or we define it as the planned and supervised process of dose reduction, or the elimination of medication that might be causing harm, or may no longer be providing benefit. And that's different than non-compliance, which is simply someone stopping taking a drug on their own. So our definition includes that supervision by a healthcare professional. And the goal is to reduce medication burden and harm while maintaining or improving quality of life. And I like to think of it really as just part of good prescribing, backing off when doses are too high, or stopping medications that are no longer needed or might be causing harm. So over the last 5 or 6 years, we've been working on an initiative to rigorously develop deprescribing guidelines. And we had funding from the Government of Ontario Health Services Research Foundation from 2013 to 2016 to develop a rigorous method for developing such clinical guidelines using the GRADE approach and adhering to agreed to specifications around developing a good rigorous guideline. We published 3 guidelines as a result of that funding, and developed 2 more with CIHR funding, as well as in working with a postdoc from the University of Sydney in Australia. So all 5 of our guidelines are available online. They're very lengthy, and I remember Kevin Potty saying to me initially, nobody will ever read these guidelines. So we also developed 1-page algorithms that essentially outline the decision steps in using the guideline around which patients would qualify for deprescribing, and then how to do that deprescribing safely, what to monitor, what sorts of non-pharmacologic options to offer instead if needed. So these are examples of the algorithms that are available that describe each of our guidelines. So the research that we've done to date with those guidelines includes taking the first three, which were on the topics of proton pump inhibitors, benzodiazepine receptor agonists, and antipsychotics, and trialing them in 3 local long-term care facilities and 3 family health teams to try to understand how they could implement them, what would the uptake be, and to get some sense of potential outcomes for patients. We have also utilized all 5 guidelines in a project with community pharmacists to determine the feasibility of community pharmacists using these guidelines in practice with their patients and with the patients' physicians. I've also been involved in a study in Quebec looking at videotaping patient-provider discussions about deprescribing to determine the elements of those discussions. And then in 2016, we also had some AHRQs, some Applied Health Research Question funding, in collaboration with the Ontario College of Family Physicians to study whether or not community engagement would be a feasible approach to implementing the deprescribing guidelines. And all of those initiatives to date have led to this DICE project, because a common theme that has come about across all of the projects is that it's fine if the healthcare providers have these algorithms and know this information, but if the patients are not coming to them with questions about their medications and deprescribing, the conversations don't always happen in practice. And I remember a family doctor from one of our family health teams saying, when patients come to me, they're not coming to me because they want to stop a drug. They're coming to me because they have a new symptom or a new problem, and I only have 10 minutes, and so I'm not going to bring in this separate conversation about stopping a drug. They need to come to me with the question about possibly stopping the drug. And so that's where the idea of community engagement came about, and could we work with the public to sort of increase their capacity and empower them to go and have those conversations with their physicians. So we, as I said, in 2016, we conducted this Applied Health Research Question study in Winchester, and we set out to try to discover what the components and processes were that would be needed to develop a community engagement intervention in their community or in another community. And we were able to identify a number of barriers and enablers and some of the key recommendations that the people we interviewed, and I should say there were 24 interviews that were conducted and 4 focus groups within the community. Their recommendations were to assemble a core group of influential advocates and champions and have that group work with us closely over a long period of time to try to identify priorities and activities in the community that would be helpful. That they would need information to support the deprescribing, so the healthcare providers would need information, but also members of the public would need information and in lay terms, and that would all have to be accessible, easily accessible to them. And then that we would need to take steps to raise awareness and support amongst the public and clinicians, and probably provide training and education, and also some focus on system level factors. What types of interventions might be needed in terms of electronic medical records or transitions of care, et cetera. And that we needed to use existing processes and venues to not necessarily create something brand new, but to fit into the community in terms of what their existing processes were. So over the last, that was in 2016, and over the last couple of years, we've had knowledge mobilization grant funding that has allowed us to develop a lot of the content that these groups told us they would need. And we've gone beyond the deprescribing guidelines and algorithms to produce patient pamphlets, infographics, whiteboard videos about how to use the algorithms. We've created an online module on polypharmacy and deprescribing that's open access on the Bruyere website, and we're currently in the middle of developing a smartphone app so that people can use the guidelines at the bedside. We've worked quite a bit on our website, which contains a lot of this content, and we've also been using Twitter and Facebook as a means of knowledge mobilization about the work that we're doing. So this is just a screenshot of the website. If you haven't been to it yet, it's deprescribing.org, and you can take a look at that and see see all of these various tools that are available there. So I'm going to bring Emily in now to talk about, to introduce DICE and here and to give you a bit of her background.
My name is Emily Galley. I recently joined Bard's team as the interim research coordinator for DICE. My background is actually in human geography with a focus on community development as well as qualitative methods. That's where I'm coming from. So DICE, which we're just getting into now, is the subsequent phase of engagement building off what the team learned from the 2016 AHRQ. The overarching goal of the project is to create scalable models for community engagement to build capacity for deprescribing to ameliorate problematic polypharmacy. Get into a bit more of how that works. Right now, we're in component 1 of the 2 principal components of the DICE project, which involves capturing the context and processes of any deprescribing initiatives or projects that have occurred in Winchester since the 2016 study. And so this is actually a twofold step. Part of it is capturing that context, learning about projects that might have gone on. This is being done through previously identified champions, so people in the know or with connections in the Winchester community that worked with us on the 2016 study or who were recommended to us during the course of that study. In addition to the qualitative interviews that we'll be conducting, that I've been conducting with them, we will also use their local knowledge to tap into potential local community champions to participate in our community engagement initiative and the local advisory group, which will be part of the second component, which Barb will discuss in just a moment. And then coming up in mid-October, the first step of component 2 will be hosting our public deprescription information night for interested members of the Winchester community.
So, so as Emily mentioned, we are starting with our information afternoon, evening for people in Winchester in a couple of weeks. We will be recruiting people for a local advisory group who we will work with in regular meetings over the next year and a half or so, doing a series of plan, do, study, act cycles that will allow us both to have that group identify what are the local priorities, what are the potential interventions that could work. We'll share with them our knowledge about deprescribing. They'll share with us what they think would work in their community, and then we'll start this series of PDSA cycles. We're using a collaborative, community-based participatory research approach, and as I said, all of the existing education and resources that we have here at Bruyere. So this slide illustrates the process of this. The step after the information night, we'll develop our local advisory group and then work with them to co-develop any resources or materials or processes that they feel would be helpful. And then we will collect data as that group goes through the PDSA cycles, both around who are the kinds of people that participate in the local advisory group, who are the people that we reach with our intervention, as well as any qualitative or quantitative information that they are interested in collecting. And part of that process, of course, will involve applying for an REB amendment to cover whatever initiative they wish to explore. So Emily's going to tell you a little bit about CPR.
So the methodology of the DICE project is very much rooted in the tenets of community-based participatory research. And I'm just going to quickly go over the key ideas behind that and how they manifest in the DICE project. So CBPR acknowledges community as a unit of identity, and community in this context can be understood as a socially created identity to which individuals can claim membership, and it usually has characteristics such as shared interests, solidarity with other members, and collective identity. So Winchester is also a spatially coherent community in that it's a town, but one of the things that the 2016 study demonstrated for the team was that it's also a community of interest with pre-existing associations, networks, and relationships through which community members interact socially and culturally, but also disseminate information. So CBPR builds on strengths and resources of the community. This is in contrast to a needs-based approach, which examines what's missing in the community or what the community might lack. And instead identifies, it can identify anything from the skills of individual community members to the role of mediating institutions like cultural groups, clubs, and churches, and the role that they play in community interaction and the dissemination of information. The next two kind of go together. So CBPR facilitates collaborative equitable partnerships in all stages of research, and it fosters co-learning capacity building for all involved partners. So while individual projects will determine the extent to which each partner is involved in each stage and the nature of their involvement, ideally the process engages all partners from the definition of the program to the articulation and implementation of interventions, the collection of data, the evaluation of the program, and then the dissemination of results. This is sort of the basis of the leg, which is envisioned as a bidirectional sharing of information between the research team and the community, wherein the community members are viewed as experts of the community itself, and the research team lends its knowledge regarding deprescribing information and the research process. So the idea is that we both get to learn something from it. One of the other key ideas is that CBPR should achieve a balance between knowledge generation and intervention. So the balance between research and action, which acknowledges that the aim of CBPR is not just the generation of knowledge, but its application in a meaningful and practical way in the lived experiences of the communities. Some of the techniques we'll use to facilitate this, to try and achieve this balance, is in the leg meetings, we'll be applying, we'll be constructing co-constructed documentation, so collaborative documentation, the use of online communication mechanisms to keep like an open and inclusive dialogue going during the process of the leg, as well as employing rapid analysis of the data, so reducing the amount of time employed in the technical aspects of data examination and more in the discussion and application of findings. And then finally, what Barb already touched on with the plan, do, study, act cycle is that CBPR emphasizes a cyclical and iterative process in which the results are never the final, the end of the study, but are meant to be built on, and in that way build more sustainable processes that can be maintained by the community itself even after the researchers have left.
Great. So this is our proposed overall design and our methods. This, of course, will have to be adapted depending on the research questions that the community asks. But there'll be a heavy focus on the qualitative component through interviewing focus groups, producing narrative reports, having participants write memos, having our staff take field notes at those meetings, and using that content as our source of information for analysis, as well as the co-constructed materials. And as Emily mentioned, we're going to use a rapid analysis approach so that in between each cycle, we will be able to, and our investigator group and staff will analyze our content and provide themes back to the local advisory group at their next meeting, so that everyone's always building on From a quantitative approach, we'll collect information around the local advisory group attendance, the demographics of participants, community demographics, web analytics in terms of it, in planning this opportunity for online communication. How many people use that? How often do they use that? What do they talk about, etc. And I imagine we'll also have some surveys as well. But again, it's going to depend on what the community chooses as their intervention. So within the next year or two, we hope that we will be capturing the context and processes around whatever deprescribing initiatives we implement in the community, establishing our local advisory group, enhancing both provider and public awareness within the community, and ultimately what we want to do is develop a scalable model that can be used by other communities to launch these kinds of initiatives and add to our deprescribing toolkit with whatever tools are developed, and really continue to build multi-level decision making among policymakers, educators, different professional groups, etc., around policy and practice with regards to deprescribing. So now we're open for questions, and I'll also encourage you to check both of our websites, our Ontario Pharmacy Evidence Network website, which has a bit more background around the research components and links to all of our publications, and our deprescribing.org website, which has a bit more of the practical information in our tools, etc. And of course, to follow us on Twitter, where we often have lively discussions worldwide about deprescribing. So, Emily, if you want to join me, we'd be happy to respond to any questions. Yes?
My name is Andrea and I'm a research associate with Dr. Babush. Thank you so much for your talk. I was wondering if you could speak a little bit about the evidence so far on the main factors that are associated with polypharmacy and how these may have informed your approach.
So the main factors associated with polypharmacy.
So what leads to
So what leads to polypharmacy? That is a challenging question. Many people are trying to understand that, and I think where some of the main factors are that the population is aging. People are acquiring more chronic conditions because they're living longer. Clinical guidelines recommend starting drugs. They never recommend when to stop a drug, or they rarely make that explicit around stopping a drug. That makes it challenging for clinicians to figure out when and how to stop a drug, because that information is generally not provided. That's how we came up with the idea of developing a deprescribing guideline, was to sort of counter that. There's also influence of pharmaceutical manufacturers, and then a lot of the education that clinicians receive is focused on adding drug therapy. I've never actually been asked by a pharmaceutical company to do a presentation on deprescribing. So, other factors, I think I'd have to look at the deprescribing literature next and look at what people cite as barriers. And some of the barriers that people cite are the specialist started that drug, I don't want to stop it. So that's challenging. Hospitalization often results in the addition of drugs, which make it challenging again for the family doctors often to know why medications have been started and how long they were intended and when to stop them. Patients also find that there are challenges in deprescribing. Sometimes it's because they've had a previous experience that's gone badly, because say they stopped taking their sleeping pill suddenly without tapering it, and then they had great difficulty sleeping. So they assumed they needed to continue taking it without understanding that the typical insomnia withdrawal lasts only for about 3 days. So there's sort of all of those factors, I think, have led to this problem we have right now, and really it's an international problem with just more and more and more medications. Simone?
So I'm really interested in the model that you're sort of trying to develop, right? So I love the participatory approach and the engagement. So I can understand the patients, the profile, the different sort of profile of patients that you might want to engage. tell me about the providers, because in the end, who are you hoping is going to deprescribe? Are we talking about the family physician? Are hospitalists involved? Are the pharmacists, do you expect that they might trigger? So maybe tell me about how that all ties together in the system.
Okay, so I think when I think of community engagement in this context, I'm thinking of all of those people as being part of the community, not just
The patients.
the patients.
No, I agree. So I understand who those are.
So yes,
Okay,
so we have already talked to the physicians and representative physicians and pharmacists in the Winchester Hospital as well as in the community. So we hope that they will contribute, and we will certainly be interacting with them because, again, I don't think it's going to be helpful to empower members of the public to go and have these conversations if we're not also involving the healthcare providers in, first of all, knowing that that could happen, but also having access to all of the tools and resources that we've been developing. I think what my concern is that if we have, say, a couple of physicians and a couple of pharmacists on the local advisory group, plus ourselves, who could be seen as experts, could we overwhelm the voice of members of the public that might be on the local advisory group? And so I'm cautious about that and making sure that we have a dynamic that allows people to say what they feel without necessarily having maybe their family doctor or the doctor they saw in the hospital sitting in the same room. So we could use some advice around that. Should the local advisory group be only members of the public, but we have kind of these experts as outside consultants that we still meet with regularly, but the generation of the ideas comes from the public group? How would you suggest?
I'll turn you to Claire Kendall, who has a lot of experience in this. So last night, we have a project where we established an intervention. It was innovative, so aspects of it had existed before, but how were we going to make it respond to this problem? And we brought patients, policymakers, or health planners, primary care providers, so we had physicians, we had social workers. They were all around the same table. Okay. And I think that process was marvelous. We had great people around the table, and there was this sort of tacit respect for one another's voice. And when the patients spoke, even though they sometimes spoke quite passionately and maybe seemed like it might have been a criticism of those who are operating the healthcare system, it was always well received. So there was people adopted values without us sort of trying to explicitly state those values. In hindsight, it might have been worth it, but that evolved on its own. So I think that bringing all the voices together is much, much richer. There was a lot of discussion across groups, and I think you're right. The elephant in the room is this perceived power differential anyway. And so how do you empower? Now it's a little more complex than that. If it's a small town, you might actually have your direct provider there.
Yes.
That might not be ideal, although we're starting another project where that's gonna happen. So we're trying to make change in the practice, and we're gonna have patients from the practice and the provider. We have a patient engagement guide, and although it's for patient engagement, I think it can be applied to a broader engagement. And so in terms of how you facilitate meetings so that people have a voice and all these things. So I'll share that with you.
I think we have it.
Okay, so that's right. So that, and I think that's what we applied to our group, even though it wasn't just patients. But I know Claire has a lot of experience in that.
Yeah, I mean, I think you've got a lot too. I think, and I think you kind of hit the nail on the head, right? How do you bring people together while still ensuring that those potential power differentials don't overly influence the direction, right? Subtle, right? They all of a sudden you can find you're doing a project or people are carried along in a way. Sometimes like doing some preparatory work, making sure people, the groups of, say, patients really have the chance to understand the questions and framing the questions their own way. So that when they come to the table, they feel solid in their grounding. And the good facilitation too, right?
Yes.
Like it was always really interesting in even our work with who could, and she was so gifted and clever at it, but she just sort of reframed the question. If I understand what this person is saying, is this, right? And if I'm hearing, you know, your screaming frustration from the corner, or what I think, and she would say, is this what you need? And it was really a great way to bring everyone together. You have those skills.
I think between the two of us.
Yeah. Well, and I think a lot of that is sort of what that'll be sort of felt out in the you know, the first meeting or so of the leg is sort of what form do the people involved want to take.
Yeah.
You know, maybe there'll be a block of community members that say, you know what, doctors already have a really strong voice. Maybe we don't want to have a heavy presence of clinicians or pharmacists. And
They're not there, they won't hear the patient's experience, right?
Yeah, so they have to be there in some way, yeah.
Right, but that, I mean, in terms of achieving that balance, there might be sort of explicit thoughts regarding. So, yeah.
Another thing that we did, and it kind of evolved over time, and I personally really like that approach. I haven't asked others whether they felt that really resonated, but at the start of each meeting, we started with, this is what you told us the last time, and this is what we did.
Yeah.
So that to reinforce the fact that everything that they're telling us, we are, so sometimes it was decisions, and that's how we implemented it, and sometimes it was recommendations, but you need to figure X, Y, and Z, and so we said, this is what you recommended, we sought information on X, Y, and Z, and this is what we're doing. That makes sense? Yeah, that's good. And so I think that for me, I felt it, hopefully it was validating people's contributions.
And I think that's consistent with our rapid analysis approach
That's right.
within the PSA. Bill?
It's very interesting, thanks, both of you. One part of it that resonated with me, or I noticed particularly, is it's sort of like a quality improvement project. So some of your language is like that, and but at the level of community, which is something I've not thought of before. So looking at it from that perspective, I wonder how you will monitor over time how you're doing. And I'm sure you'll be discussing this with your group, but one possibility would be to just get the postal codes for Winchester and go into the ICES databases and get all the OBD, just get a prevalence number for people with certain definition of polypharmacy, and dig in a little deeper. What are the drugs that seem most likely to be inappropriate and possibly stop and so on. So I realize that would make, that would be really easy to do, and it would be inexpensive, and you can do it at multiple points in time, sort of monitoring how you're doing and so on. But it would certainly make it less generalizable to other communities. If your intervention wouldn't be as easy to do in other places. So any thoughts about that?
Well, we did have a component in our original application that essentially did that. We were working with Suzanne Cataract at Faculty of Pharmacy in Toronto, who's an ISIS scientist. And we ended up, because of the large budget reduction from HSRF, eliminating that component. So I'm interested in your comment that it wouldn't be that expensive, because I was told it would be $70,000 or $80,000
Oh,
to
goodness,
do
no.
that.
I think it would be $7,000 or $8,000.
So maybe we should talk then to figure out if there's a way to do that.
It depends if you were trying to link individual patients or individual, but if you're just looking at a regional level, I agree with you.
Okay.
It does, it's an interesting idea from a quality improvement perspective, to be able to monitor progress or lack thereof, but it does mean that your intervention couldn't be picked up spontaneously by another community, because they'd have to have this link to get this.
But could they not still implement the intervention without the measurement component? Yeah. But I think the measurement component would be really valuable. I've always just been advised that it's a lot more expensive than what you're suggesting.
So But there's not-
Simone can do that kind of thing in her sleep.
Okay.
I see that you've already adopted the ICS lingo.
Yeah,
Because
it
we
goes
don't say
over a little
ISIS
better
anymore.
than ISIS.
Oh,
So
I
that
see,
wasn't
yes,
a,
right,
sort of
right,
a-
right.
So help me understand, are you developing sort of, the model and how it look like, or this is actually an intervention in deprescribing? So are you hoping, is it a process development or,
I'm not exactly sure
yeah,
how it's going to work until we meet with the members of the community and work with them to identify what they need, essentially to facilitate them having conversations with their care providers. It could be that they ask for a public awareness or education campaign, or maybe they ask for different types of written material.
but what I'm trying to say, so are you gonna come up after this with, this is the recommendation of how we'd implement it, or you're actually gonna come out with, well, are you trying to get people to
Right.
actually deprescribe during that session, or is it a process learning?
I think it's both.
Yeah.
Okay.
I mean, I feel like that would be sort of a measure of success of the
Okay.
process, right? So going back to measuring success, I mean, that'll be
Yeah,
part of,
I'm a bit surprised about the measurement.
that'll be part of the local group as well, is to determine, according to their concerns and their eventual choice of intervention, what constitutes success, and at what point have we accomplished that stage of the process and achieved a successful, what they feel is a successful result, or what can be measured, or.
So one of the models that I used in coming up with this idea was the cardiovascular health awareness program, which I was involved in from the sort of very beginning, and doing some of the exploratory work in community pharmacies around, could you have a blood pressure clinic in a community pharmacy, and who would you provide the information about the patient's blood pressure to, the pharmacist, the physician, how would they communicate with each other? And when we started, it was very much a exploratory feasibility. Could we even do this? And over time, it developed into a program where an instruction manual was created for a community on how to implement these blood pressure clinics within community pharmacies, and kind of communicate that information to the family doctor, and did that not ultimately, not just reduce blood pressure, but did that have a difference in strokes and heart attacks and hospital admissions, which in a randomized controlled trial in Ontario, it was demonstrated that it actually did reduce strokes and heart attacks. So that though was sort of a 15-year process.
Well, that's what.
So this, I think what we are looking at is the feasibility of doing this kind of community engagement intervention from a process perspective around forming a local advisory group, having the public work with the clinicians to come up with something that might work in the community. If we find something that seems very feasible, that initiative itself could be implemented elsewhere. But when I refer to a scalable model, it's also, I think, the model of using the community engagement approach within a community to identify initiatives that might be beneficial for deprescribing. Diane?
Two questions. One of the things I'm thinking about is choosing wisely, which is looking at patients as well. And this is similar if you think about it. Choosing wisely looks really at investigations, but this is about treatment and whether you choose it or not. So you might learn from that approach as well, like rather than invent our own wheel. The other piece was that when you started out, you started talking about frail elderly. So in your community engagement, are you targeting an age group, or are you looking at all adults?
No, we're not targeting an age group in the sense that we hope to attract anybody who's interested in the issues. So it could be people who are experiencing polypharmacy themselves and they're concerned about that. But as well, I mean, in other investigations, have talked to family members that are concerned about like older family members' issues with medication, caregivers, applied health professionals as well, like non-long clinic, allied health professionals as well. So, I mean, that'll sort of be part of the initial exploratory phase in informing like advertising and recruiting for the leg is for the local advisory group. is to, I mean, basically anybody who's interested in the issue rather than specifying any kind of age. Because a lot of people might not have the problem themselves, but they have care of or concerns for somebody that does.
Because the other side of this coin is non-compliance. And you don't want to be going down the path of deprescribing and getting to a place where people aren't. And my husband works with the severely mentally ill who refuse to take their medications.
Yes.
And they end up in jail.
Yeah.
So, this is not a good outcome for people to take the messaging correctly.
So we need to be very clear in our messaging, which we have always done in any discussions with the public, and that's why I always make it very clear that it's not about just stopping your medications. This is about a supervised process by a healthcare professional.
How did you deal with that in your ethics application?
Deal with.
The unintended consequence of somebody deciding to stop a medication that they shouldn't stop.
That has not come up in the ethics applications that we have.
Well, believe me, I'm with you that there's far more medications being taken than should be taken, and that deprescribing is a very powerful, positive thing.
Yes.
But it does seem to me that you have to have an answer for, to say we're going to be very careful and tell people they shouldn't do that is fine, but in fact they may.
So we get emails from people all the time that ask us questions about wanting to stop their medications. Whenever we do knowledge mobilization events in public venues, we get questions about that, and everyone on the team is very clear in the messaging. You should never stop a medication or reduce medication without talking to your healthcare provider. So
I think you need to measure it someday. This is going to be an awkward question for you. And
how would we measure that?
Well, you could do it. I really think if you're inspired by the CHAP program, and that's where this work may go someday, as part of your piloting feasibility work, you need to have a connection to the databases at ICES, because you're going to, it would be trivial to identify every small community in Ontario that has a particularly high rate of polypharmacy. It would be really, once you've got your little software written to give you the report you want for Winchester, you could, for $2 extra, you could do it for every community in Ontario, and you could also ultimately get, see if there's differences in mortality rates or hospitalization rates, or all those kinds of things. You're going to want to do that.
Okay.
So I think you got to build that connection early on.
Okay. Sharon and then Claire.
It was just, as you are engaging more with community members, deprescribing is the medical act, that's for your physician audience, and trying not to conflict with the tremendous push at appropriate medication taking. You're looking at what you want members of the public to do. It's not just start or stop medication, you're talking about asking the right questions, coming forward and asserting their interests, informing themselves. It's a whole process. And so the terminology about what you want your community to do, smart medicine, or something that's capturing what they do. And that could link quite nicely with, there's a serious train going forward on the compliance and taking your medication. And you can hitch it to that because it's all linked to what you want engaged communities and patients to do. So just saying, look at, as you work with them, what you want them to do, because it's not deprescribed.
And the language around that is important. CADIT has actually done a series of focus groups with members of the public around concepts of deprescribing. So I think bringing them into the discussion would be helpful too, to find out what they've learned through those discussions. Claire?
I was going to sort of echo that, just that I don't perceive the same risk actually to people. I think what you're promoting is, first of all, you're looking at a discrete set of medications, none of which have ever been perceived to be life-changing for anyone, right? And I think it's promoting a model of shared decision-making,
Yes.
right? And we should argue that even people with severe persistent mental illness have
Mhm.
as long as you've been able to share a diet. Now, obviously, there going to be some extenuating circumstances, but or I'm thinking people like with HIV, some people are going to decide that they don't want to be adherent to their medications, and it's our role to create a space to
Mhm.
talk about it in a rational way.
And I
I
think,
don't perceive as much harm, I don't think.
I think that's a good way to frame things in using the shared decision-making model. So making people aware that there are options around whether they continue or reduce a medication. What are those options? How do they express their preferences around those options? And then how do they make a decision? And the importance then of revisiting that
Right,
decision.
and the risks and benefits.
Yes.
And 5 years ago, we would have told everyone they were absolutely foolish not to take an aspirin.
Yeah.
They had diabetes, right? And today, now we're like quickly
Yeah.
scaling back, right?
Yes.
And we'll never scale back. That's the problem. We will never scale back appropriately because we won't apply that kind of concept of deprescribing being a form of not doing harm, not doing harm, right?
Okay, thanks very much. This was
Thank you.
wonderful.